Good morning, friends. Today our guest speaker is Associate Professor Dr. Amit Khote from Australia. He is going to speak to us on ultra-high-risk myeloma. This webinar is brought to you by Mumbai Hematology Group. It is supported by Janssen and Nirvin Life Sciences. It's managed by Perfect Square. I thank Dr. Uttiya Deb, Mr. Hitesh Khandelwal and the team from Janssen, Mr. Paresh Prabhugaonkar and the team from Nirvin, Mr. Yash and Kalpesh and their team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Colonel Dr. Uday Yanamandra from Pune, our guest speaker, Professor Dr. Amit Khote from Australia. All our discussants were themselves eminent hematologists or hemato-oncologists from India, Bangladesh, and UK. You participants for sparing your Sunday morning. Just to introduce you to the next weekend educational sessions, on Saturday, IST 7 p.m., 3rd June, we have Dr. Alison Moliterno from Baltimore speaking to us on thrombosis in myeloproliferative neoplasms. The next Sunday at 11:30 a.m. IST, that is 4th June, we have Dr. Barnali Das. She's biochemist and immunologist from Kokilaben Dhirubhai Ambani Hospital, Mumbai. And she will be speaking on the harmonization of biomarker reports on monoclonal gammopathies. To introduce our discussants today, and we have a galaxy of them, they've been all put up here alphabetically. They're from India, Bangladesh, and UK. Just briefly introducing them, we have Dr. Jaswantini from Yashoda Hospital, Hyderabad. Dr. Aba Dubey from Shelby, Ahmedabad. Dr. Akanksha Chaudhary from Kidwai, Bangalore. Dr. Ankit Jitani from Marengo Sims Hospital, Ahmedabad. Dr. Ankit Rayani from Cure, Ahmedabad. Dr. Ankur Ahuja from AFMC, Pune. Dr. Avriti Baveja from Himalayan Institute of Medical Sciences, Dehradun. Dr. Bharat Parikh from HOC Vedanta, Ahmedabad. Dr. Chandrasekhar Bendi from Mahatma Gandhi Cancer Hospital, Vizag. Dr. Chirag Shah from Apollo, Ahmedabad. Dr. Dinusha Chaturani, she's MD hematologist from Sri Lanka, FRC Path, UK, consultant hematologist, Royal Oldham Hospital, Great Manchester, UK. Dr. Gautam Panda from American Oncology Institute, Nagpur. Dr. Humaira Nazanin, she's assistant professor, Department of Hematology and Bone Marrow Transplant Unit at Dhaka Medical College Hospital, Dhaka in Bangladesh. Dr. Jyoti Bajaj Savne from GCRI, Ahmedabad. Dr. Kamil Kumar Patel from Maregno Sims Hospital, Ahmedabad. Dr. Kunal Chattani from Nagpur. Dr. Meenu Angi from Unipath, Ahmedabad. Dr. Neeraj Arora from Unipath, Ahmedabad. Dr. Nudhi Jain from Zydus, Ahmedabad. Dr. Priyanka Srivastava from Kamarset, Gujarat. Dr. Rajan Yadav from GCRI, Ahmedabad. Dr. Ranjit Varghese from Kaman Hospital, Pune. And Dr. Sandeep Shah from Vedanta, Ahmedabad. Dr. Shruti Toshniwal Mantri from Aurangabad. Dr. Siddhesh Kalantri from Blood Care Hematology Clinic, Nashik. And Dr. Sumit Mirk from TMC, Attract, Mumbai. To introduce our chief guest for the day, who is going to inaugurate our webinar, is none other than Dr. Colonel Uday Yana Mandra. All of you know him. I complete the formality of introducing him. He's MD, DMSS, DNB, MNA-MS, and DM in clinical hematology. He's professor of medicine and hematology at the prestigious Armed Force Medical College, Pune. His academic qualifications I have just mentioned to you. All along in his life, he has received and achieved gold medal at various levels. His academic achievements include Colonel S.N. Prabhakar Gold Medal, Brigadier I.P. Bhalla Gold Medal, Chief of Army Staff Medal, late Shri Sudhir Singhal Gold Medal, Sam G.P. Moses Gold Medal, and Rashi Memorial Medal. He is a rank holder from Pune University in forensic medicine, microbiology, and ophthalmology. His research publications include 175 prestigious papers in 90 PubMed index journals, H index of 12, and RG score of 37.35. His research awards include Chief of Naval Staff Award, AFMRC 2022, awarded FICP 2021, International Young Investigator Award in High Altitude Medicine, Italy, Bolzano 2014, Ash Scholar San Francisco, USA 2014, Brisbane, Australia 2016, International Development and Education Award, ESCO, Chicago, USA 2016, Dr. D.P. Basu Young Cardiology Award, API 2018. His research awards include E-Merck Award, API 2019, Best NBE Young Achiever Award, ANBAI 2021, Dr. J.C. Patel Best Paper Award, Mumbai Hematology Group 2021, Best Oral Paper Award, 4 of them, ISBMT Korea 2021, India Myeloma Congress, Mumbai 2019, International Cancer Congress, Delhi 2017, Hematacon, Hyderabad 2014. He's examiner for MD Medicine, DNB Medicine, and DRNB Hematology. I request Colonel Dr. Uday to inaugurate our today's webinar and give some words of wisdom. Uday, you can share your screen.
Thank you, sir. So Firstly, I would like to thank MB Agarwal sir for giving me this opportunity for being the chief guest for this. I really doubt if I deserve this with the type of panelists that we have and with sir being my teacher who taught me during my both MBBS days and MD days. So, but there are few things sir has specifically asked me to be totally non-medical about it. So I felt that there are few messages which the young hematologists, the students, and even the practicing hematologists, we should all be following during our life to be the best in our life. So the first and foremost thing is the parampara of Guru Shishya. So many of you might be at the level of the Guru, many of you might be at the level of the Shishya. So the biggest complaint which I heard many times from the people is I didn't get a good mentor. So now when you are teaching a students, a batch of 150 people, you can't be mentoring everybody equally. So it is the responsibility of the student to stand out among crowd and to impress the teacher that he's the best mentee who can be possible for that given teacher. So as all students, rather than we complaining that we don't have good mentors, we need to showcase ourselves, prove ourselves to the mentors to get good mentors. Now, for those of us who are at the other side of the story, wherein we are mentors, mentoring just does not mean training, motivating, supporting them or coaching them. But most importantly, which I feel is lacking with the current generation, is to be happy with the success of the mentee. The biggest happiness that a teacher or a mentor would get is when they see their mentee performing or outperforming themselves. So finding happiness in that would actually go a long way in propagating science and in propagating the success of your students. Now come to the second aspect. In early 1900s, the Ford started the concept of assembly line. You might be thinking, why am I showing it here in a hematology forum? The whole concept, people just felt that from the carts, horse carts, it led to a revolution of motorades or the cars that we have currently. But one very important aspect that Ford started was the concept of assembly line and checklist. When I equate it to our hematology practice, we are a practice where we are not individualistic in our practice. We require team, whether it is transplantation, taking care of various critical patients. It's always a teamwork. And in the team, all are never equal. You have people of all competence, of different knowledge. The important aspect to bring homogeneity when you look at the outcome or for making sure that you have the best possible product or the outcome or in the form of survival of a patient or the outcomes of the patient would be to have a good checklist. So the assembly line teaches us the concept of having checklist for everybody who is part of the team. So when you as a team leader could create checklist for everyone, it will go a long way. And the best example is the airline industry. Whenever most of you fly from one place to another place, when a flight touches down, there's a huge crowd of ground staff who come there of different competence. But everyone knows exactly what he's supposed to do. He's supposed to tick mark that I have done this particular job. And that's why if you look at the number of airline accidents versus road traffic accidents, you clearly find the difference. So to prevent accidents in our career, in our patient outcomes, it's always good to have a concept of checklist and to make sure that as a team, we outperform than the individuals. The second concept which I would like to bring forward is a concept of what is known as a rudder flap. Now, if you look at this huge ship, aircraft carrier, it has to make a turn. If you look at the torque, the physics of it, and if you look on the right-hand corner, the old German flaps which were there, they were so huge, it used to take a lot of time and a lot of effort and the energy and the fuel to take a turn. And it never used to take a small turn. It had to take a huge turn, a turn with a radius of maybe around 10 to 12 kilometers. But that doesn't work in the modern warfare. So the concept of rudder flaps came in. Now, what is this concept is mechanism within the mechanism. So if you look at the bottom, rather than having a huge rudder flap, which goes into 20 feet or 30 feet, now the concept is you have a rudder flap, which has got small flaps within. All these small white colored dots that you are seeing are the flaps within themselves. So this teaches us in hematology or in our routine clinical practice, a concept of mechanism within mechanism and getting into the nitty-gritties of it. So when you find a problem, a particular patient not doing well or your team not trying to take care of a critical case properly, rather than just saying your team theek nahi hai, or just saying that this whole mechanism doesn't work, you need to go into the mechanism within mechanism. So every individual or the smallest component, from the safai wala or a sweeper in the ward to everybody, have their own roles. You need to identify what is a small mechanism which has gone wrong, which has led to the difficulty in turning the whole ship around. And if you could take care of these small aspects or the small rudder flaps, the minute mechanism within mechanisms, the life and the overall aspects improve. The next concept is about intelligence. Nowadays, everybody talks of artificial intelligence. Now, there is a Gardner's theory. There are different types of intelligence in human beings. The most important of them, I feel, for hematology is existential intelligence. Now, I'm not going by the literary meaning of it or the actual psychological meaning of it. In hematology parlance, I feel we are a naive specialty or a recent specialty. For us to prove ourselves and to make sure that we create our existence in the community or in the society, it is important to behave. And our behavior might impact the life of another hematologist. I'll just give you an example. There was a corporate hospital here in Pune, wherein there was a hematologist, and for every anemia case, he used to call the MD physician, यार anemia मुझे क्यों भेज रहे हो, तुम नहीं manage कर सकते क्या? Thrombosis मुझे क्यों भेज रहे हो, तुम नहीं manage कर सकते क्या? Why are you giving me a call in the night for a neutropenic patient? Can't you manage as an MD physician? Well, he was right technically, but what happened? For a period of time, he not only lost his job, but the corporate had taken out the total department of hematology, saying that there is no requirement of benign hematology. Now, the same anemia patient, if he happens to go to teachers like MB Agarwal sir or Velu Nair sir, they would look into it, they would create a case scenario out of it, and would teach 10 more points to the juniors. So, our existence can only be proven if we are sincere to our specialty, start dealing every patient with complete interest, and to prove to the society and the community that we are as important as a cardiology or any other specialty. And the last aspect which I would like to bring is, we all understand old is gold, and it is very important. Nowadays, we see many young physicians or the students saying that, okay, आज के तारीख में ये monoclonal available नहीं है, आपका इलाज नहीं हो सकता, and they send back the patient. But they forget that our predecessors, our previous people have been treating with the normal drugs for almost 30 to 40 years in this country. With the experience of teachers like MB Agarwal sir and Velu sir, they have been handling such patients for 40 years without monoclonal, and their outcomes, I would say, were maybe better or at par with the current outcomes. I'm not denying that new is diamonds. You require all the newer aspects. But if you want a good earring or a finger ring, you require a combination of the gold and diamond to come out as a good pendant or good ring. So you need to have a good combination. You cannot just say that in the absence of diamonds, I will not use gold. So we all need to understand, and the best way to do this is book reviews. If a patient comes to you with a notebook having all the old cases or the notes of the previous predecessors or the elderly teachers, just go through them and you will understand that patients can be managed even in the absence of these newer drugs. So just denying therapy to the patients in the lack of newer drugs is not a good concept. And I would like to end it here and not take it any further and eat away into the time of the guest speaker for the day. And thanks a lot to MB Agarwal sir for giving me this opportunity.
Well, Uday, thank you so much for being with us and giving those lovely messages. I'm sure that they will be extremely useful to our next generation, including people like us. I'll share my screen now to introduce our guest speaker of the day, and that is none other than Professor Amit Khote from Australia. So, first of all, I'm grateful to Dr. Amit Khote for sparing his time, accepting our invitation, being with us. To introduce him formally, he is MBBS, MD, FRCP UK, FRC PATH, FRACP. He's clinical hematologist and a bone marrow transplant physician. Myeloma and autologous transplant disease group lead, Department of Clinical Hematology at Peter MacCallum Cancer Centre and Royal Melbourne Hospital at University of Melbourne, Victoria. After graduating from the University of Pune, he trained in internal medicine in India and UK, where he qualified as a member of the Royal College of Physicians. He completed training in lab and clinical hematology in London, UK, obtained a fellowship from the Royal College of Pathologists. This was followed by a clinical research fellowship involving early phase clinical trials in cell therapies and myeloma at the Peter MacCallum Cancer Center. He has published widely in international journals and presented in international conferences in his fields of interest of cell therapies, hematopoietic progenitor cell transplantation, myeloma, and early phase clinical trials. He currently works as a consultant hematologist at the same institution, that is Peter MacCallum Cancer Center and Royal Melbourne Hospital. He is an investigator in all phases of clinical trials involving novel agents in myeloma and other advanced hematological malignancies. Today, he is going to talk to us on ultra high-risk myeloma. Myeloma, high-risk myeloma, ultra high-risk myeloma, double hit myeloma, triple hit myeloma, myeloma, those who do not do good, picking them up early by sophisticated tests, prognosticating them, and probably some method of handling them. And I'm sure with all this material, we are going to be educated by this wonderful personality today. So over to you, Dr. Amit Khote. Once again, thank you so much for being with us. And you can go ahead with sharing the screen.
Thank you very much, Dr. Agarwal, for the invitation and the opportunity to do this talk. So I'm just going to start my screen sharing. Can you see my screen?
Yes.
Thanks.
Yes, perfect.
So, as I said, it was great to hear the introductions and also to see a lot of members online of this forum who are from Pune and around Mumbai, where I grew up.
This is the full screen mode?
It's on slideshow mode right now. Can you please? Yes.
I've got my, hopefully it should go.
Got
it, yeah. And so it gives me a feeling of nostalgia as well to hear from Dr. Yanamandra, who's in the city where I was born and did my all my schooling and early medical education. So it's been a longish journey moving through Pune, then Mumbai, Tata Hospital for a year and a half, then moving to the UK, where I was at the Royal Marsden, where I did my hematology training, and other places around London, and then to the Peter MacCallum Cancer Center. So just reflecting on 20 years of, or more than 20 years of treating myeloma patients, and starting out from an era where thalidomide was just coming in on the background of a few chemotherapy drugs, VAD and Malphilan. And I remember very few people wanted to actually be involved in myeloma care at that time, and how things have changed in 2 decades. But there still remains a group of people, a group of patients for whom the outcomes still aren't great even today. And that's, I think, an area of high unmet need and something we need to focus on. And so that's going to be my talk today on ultra high risk myeloma. Now, the term is relatively new, and there is a lot of overlap with high risk myeloma, and we'll talk about the areas of difference, but there is a lot of overlap in the area. So I'll cover the historical aspects, the definition, what we have currently, and how it works in this field, and then talk about future prospects, and that's the really exciting area. So given that there's some trainees in the audience, I would like to start any talk in myeloma with a few historical aspects. One of them is Henry Bench Jones, and I did part of my training at St. George's Hospital in London, South London. And there's a bust of Henry Bench Jones, which you walk past every day as you walk into the hospital. And he was a biochemist. And he was the first one who precipitate, which occurred when the urine was heated to 60 degrees, and then on further heating, this precipitate dissolved. But the actual case was first, the case that was sent to him was described by a physician who had noted the anemia, bone disease, renal disease, and had asked Henry Bench Jones to look at the biochemical aspects of it. So this physician was William McIntyre, and he published his clinical aspects of the paper a couple of years after Henry Bench Jones. Now, Henry Bench Jones has become immortal, and William McIntyre, nobody really knows unless you have like this interest in history. And so if you get or see something new and want to publish something new, get it out quickly, because you may be compromising your immortality. So it's known by different names. It was known by the name of Caller's disease in Europe, and the field of myeloma has far, had an impact beyond just the myeloma therapy itself, because the whole field of monoclonal antibodies across medicine has come from myeloma research. It was one of the first cancers to be treated with a non-chemotherapy agent, and up to very recently, I haven't looked at the most recent data, but the number of clinical trials in myeloma far outweighed any other cancer. So it's always been a very dynamic and far-thinking group of doctors over time. And the other bit of something I found out relatively recently is that the kappa and lambda light chains actually refer to the initials of the biochemists again who described the light chains initially in the 1950s, Korngold and Lipari. And again, so I thought that was a sneaky way of ensuring immortality. So just moving to what we know about myeloma development or disease biology, we know that every myeloma develops from precursor states of MGUS and smoldering myeloma. And then over time, there are a whole series of changes in the microenvironment and also genetic changes, which mean that the disease is quite different over time. And our current paradigms of care do not take this into account. We treat the disease empirically. We stage the disease. We look at the cytogenetics, but we still treat the disease empirically. We give a certain group of drugs at presentation. We change over to maybe a new group, put different combinations over time. But we're not doing risk-adapted therapy or response-adapted therapy. We're still treating all patients the same, even though we know that a significant proportion of them will not do well on the treatments that we currently have. So that whole paradigm has to change and is changing. But like the analogy of the aircraft carrier, it takes time. So this is just to illustrate what a whole genome of a myeloma patient looks like at diagnosis, maybe about 50 rearrangements, deletions, and at the molecular level, about 5,000 changes that we get. So that's a diagnosis in the Circos plot. And the same patient at relapse is a whole different ballgame. There's a logarithmic change in the numbers of genetic changes. But we still treat patients. We don't take this into account when we treat patients. So that's a measure of the challenge that we face. Now, this term of ultra high-risk myeloma is relatively recent. The first mention that I could come across was about 13 years ago in the ASH educational program, where a senior myeloma physician from France wrote this review. looking at what we know are very well-defined poor prognostic factors, a gene expression profiling model, del17p, plasma cell leukemia, and the parts of the ISS, which is the beta-2 microglobulin. So he defined it at that time as myeloma, which had a survival of less than 2 years. And so this was the first reference to this entity of ultra-high-risk myeloma. So, but that's moved on a little bit. It's still a bit of an arbitrary definition, but over the last sort of 2 years, expert consensus is that anything with a median overall survival, any myeloma entity with a median overall survival less than 3 years is ultra-high-risk myeloma, and anything which is less than 5 years is high-risk myeloma. So, looking at our classical or known models of prognostication, we've got the revised international staging system from 2015 based on 2 very simple biochemical parameters of beta-2 microglobulin and albumin. We've added the LDH onto that from the original ISS, and we've added cytogenetics with the 414, 1416 translocation and del17p. Again, it defines that high-risk group of revised ISS3, which we know have a poor 5-year survival. Other groups like the Mayo Clinic, they have been quite active in this area of risk-stratified treatments. And in fact, I mean, they were probably amongst the first to tailor treatments or proposed treatments according to risk categories, mainly cytogenetic risk categories. And so again, the same 414, 1416, del17p, TP53 mutations, and more recently, we all know we've about gain 1q and amplification 1q, which impact on prognosis. And there's now the entities of double hit myeloma, which I'll talk about in a bit more detail moving forward. Now, this paper from by Walker in about 3-4 years ago from the Myeloma Genome Project, which looked at outcomes, relatively recent cohort of patients treated in the prior sort of 10 to 15 years, and looked at their outcomes and looked at their various genetic and molecular profiles. And the 2 entities which came out to be the highest risk, one was TP53, particularly biallelic TP53 deletions or silencing. So this marker, when you've got biallelic deletions or alterations of TP53, that is associated with the less than 2-year overall survival. So this definitely fits into that that paradigm of ultra-high-risk myeloma, however you define it. And then when you add on a 1q amplification, that it may also provides a very high-risk group. So biallelic TP53 mutation and the double hit, the combination of TP53 inactivation and 1q amplification. That is a very, very high-risk category of patients. Now, they also looked at, as part of that paper, they also looked at what the outcomes with what was the most intensive regimen of treatment in myeloma patients developed over that time period, which was called Total Therapy 3 from Bart Balogi's group in Arkansas, which combined every possible treatment or class of drugs, chemotherapy, Velcade, thalidomide, transplant, consolidation therapy, and maintenance therapy. I mean, that was a 3-year package. It was like a huge burden of treatment. I mean, it's interesting that in the high-risk group, the double hit group, it's maybe moved their outcomes a little bit, which is the blue curve, but not by a whole lot. So everything that's been thrown at this entity has moved their outcomes marginally. But interestingly, in the high risk, in the standard risk group, there is the potential for cure because that curve seems to be plateauing. And so you can see patients who haven't, a significant proportion of patients who have not progressed at even 10 years. So that is, for all practical purposes, an operational, functional cure, whatever we like to call it. I suppose those of us who've been treating myeloma for a while are always hesitant to use the word cure because we've seen relapses beyond 10 and 15 years. And so, but anyway, it's a significant significant improvement when you put all the treatments together in the standard risk group. Now, whether that can be translated into the high risk group and the ultra high risk group is something we'll talk about as we go along. Now, recently, there was this paper from the French group which added another abnormality, deletion of 1p32, which has been known about for a while. But a biallelic deletion, again, is in the same ballpark of the other described double hit, and the TP53 biallelic mutation and the double hit, because these patients' survival is less than 2 years. And the other sort of recent concept, which the French cooperative groups have shown in over the last 3 or 4 years, is when you add cytogenetic abnormalities, there is a synergy. There seems to be some degree of synergism between the various poor risk prognostic markers, because once you get beyond sort of you add 2 or 3 adverse risk factors, these patients again move into the ultra high risk group. So you can see the difference in those curves. There's a big difference between those patients who have 2 or more high risk cytogenetic abnormalities versus those who have none. So, and again, the previous paper from the French group, they developed a risk score based on these abnormalities. I mean, the ones we've spoken about already, and they also had some trisomies in there, and there were different weightage given to each of these abnormalities. You can see that in the high risk group, their median survival is less than 3 years. So, or in the ultra high risk, what we would define as ultra high risk. And that's the issue around terminology. Most papers talk about high risk abnormalities, relatively few, and there is more a move to talk about this ultra high risk group, but the vast majority of the literature just mentions high risk. So, so there are other factors as well, which we focus primarily on the cytogenetic or molecular abnormalities, but we know about clinical features. Like every myeloma physician knows about things like renal failure, extramedullary disease, plasma cell leukemia, plasmablastic myeloma. All of those also have poor outcomes, and they're not very well characterized in the current risk scores. Frailty is a very important aspect, which I mean, we think that older patients who have comorbidities, their disease biology may not be too different from younger patients, but it's the ability to deliver treatments effectively, which is the issue in that group. And functionally, they are high risk and their outcomes are poor because a big factor in that is therapy is difficult to deliver. So this is this curve, or this series of curves from the US SEER data population database is very well reported, and any myeloma talk for prognosis always shows this, showing a huge difference in outcomes in that decade between 2000 and 2010, the impact of novel therapies. It created a huge shift in survival over just a decade. So And there's a more recent US population study, population-based study, which has shown that improvement in outcomes, which into the subsequent decade. But I thought the most interesting part of this paper was that even at 5 lines of therapy, median survival is still 2 years, which was not the case before. I mean, before the older papers suggested that when you're beyond 2 lines of therapy, survival was extremely poor, less than a year. So all the agents that we have are effective and remain effective over time, in spite of multiple lines of therapy. So that's an encouraging aspect of myeloma treatment. We've just looking at some local data that we're involved with on this side of Asia and the Asia Pacific. So there's some combined registry data along with Australia. Registry we started about 10 years ago, which tries to get a lot of myeloma patients on board and follow their outcomes outside of clinical trials or as part of standard of care. And that's showing that pretty much fairly similar outcomes across the region. Median survivals of about 5 to 6 years on average. So it looks like, and this is an unselected population. So this includes older patients, younger patients, everything. This is all unselected population-based data. So that was progression-free survival, and this is overall survival. Now, again, in other areas of the world, this is a German population-based study, which has shown improvement in survivals over the years, but most notably in the younger cohorts. The older cohorts, we have made some progress, but the progress has been nowhere near as much as the younger cohorts. And this is some local Australian data from New South Wales, which is showing that every 5-year period, there is an improvement in survivals. The slide's been repeated. Now, I looked at the data from India, and be very interested in the discussion to hear Dr. Yanamandra's thoughts on his paper as well, where excellent outcomes over survival outcomes over 700 patient cohort, with the usual issues and less favorable outcomes in patients with renal failure. I was interested in this aspect of anemia having a negative prognostic impact on outcomes, and there's also weight loss, which is a negative prognostic impact, but that, I suppose, is a marker of performance status, so it's to be expected. I think cytogenetic data was available in a relatively small proportion of patients, so that is something, I suppose, that will need to be added to future cohorts of outcomes. So this is our just going the revised international staging system. And sorry, it looks like some of the slides have been repeated. So. And so let's look at how can we impact on those prognostic markers. This is a timeline of myeloma treatments over the last 150, 170 years. For the last 50 or the second half of the 20th century, we pretty much had melphalan, steroids, high-dose melphalan, and a few other maybe chemotherapy drugs, maybe adriamycin, vincristine, probably not very effective. And then the whole change occurred over from 2000 onwards with the IMiDs, the proteasome inhibitors, followed by other drugs which actually have approvals like HDAC inhibitors, like panobinostat, because they were positive phase 3 studies which improved, studies which met their primary outcomes of improvement and progression-free survival, but they've never really come into practice. So, and then we obviously then had the next big step of daratumumab being added into the armamentarium in the last 10 years. And then now we're moving into the immunotherapy era with bispecific antibodies and CAR T cells. So, so that's the timeline that we've got. We've got another drug called selinexor, an exportin inhibitor, which again is relatively effective but difficult to deliver in terms of its side effect profile, the same as with panobinostat. So we know that we've got a lot of drugs in the mix. We've got another one, ilotuzumab, an anti-CS1 antibody, which very limited single agent efficacy, again approved, but is likely to not find its way into widespread practice because there's so many other more effective drugs available. So this is just a cartoon showing the various targets that we've got that we can work on. And one important one, particularly the center that I've worked in, I've been fortunate enough to be involved with the development of venetoclax, because all the preclinical work and all the early clinical trials of venetoclax have all been out of Melbourne and the center which I work in. So it is remarkably effective in patients with 11-14 translocations, and there is another cohort of BCL2 high expression patients as well, where we don't have the classical translocation cytogenetically, but do express high levels of BCL2. So we've seen remarkable results, patients who have been on treatment for up to a decade or more now in CR or near CR, and remaining stable for more than a decade. So that is a very interesting area, and that's about 15 to 20% or more of myeloma patients. So that will definitely need further exploration. And if we had to list them out, these are the drugs which we list out as of last month. And interestingly, belantamab, which had approval, which is the drug antibody conjugate, had approval in the US from a couple of years ago based on the phase 2 study, the first phase 2 study, has already been, or I think already been withdrawn now because the phase 3 study in combination was not positive. There's a whole lot of suite of studies to read out with that BCMA drug antibody conjugate, but it does look like that it may not move forward because the competition from other drugs is quite fierce. So an exciting time, but also when you've got when sometimes more choice is also a difficult thing when it comes to narrowing down treatment paradigms. So let's look at current standard of care, which is VRD, induction, transplant, and then consolidation and maintenance. So multiple large phase 3 studies showing a benefit for VRD. Now, the question of whether transplant is required or not. Now, I'm a transplanter, so maybe I'm a bit biased, but as of today, and I think for the next 10 years at least, I don't see transplant coming out of the paradigm. If CAR T cells or the bispecific antibodies show a huge benefit in the randomized studies outside of transplant, then maybe things might change. But for the last 30, 40 years, everyone's been trying to avoid high-dose melphalan and transplantation, and hasn't and all the very large trials have all favored transplant. Definitely for progression-free survival, occasionally for overall survival, but it remains part of the paradigm. And I think it's interesting that in this current era of immunotherapies, which are very effective, but also going to be hugely expensive, a transplant has actually become the cheaper option with a significant survival benefit. So This was a study, or probably the last study that will be published in this area of RVD from the New England Journal, published last year. And it's showing a benefit, as I say, for when transplant is used in frontline therapy versus the other group which had RVD and no transplant. So there is a significant benefit for its primary endpoint of PFS for transplant. But in the group that we're interested in, which is the high-risk cytogenetics, again, there's an even bigger impact for transplantation in terms of difference in survivals for the group with high-risk cytogenetics, as compared to the group which had standard risk cytogenetics. You can see that there's quite a significant difference in the curve. So so it may be that we as we move forward, transplant, at least in the short to medium term, remains the therapy of choice in high risk patients. Maybe with a proportional standard risk patients who achieve MRD negativity may not need transplant. We'll probably know that answer within the next 5 years. And the concept of MRD again is important because, and we'll be sort of working through these concepts over the next part of the talk, is that MRD or measurable residual disease or minimal residual disease, it doesn't matter where you are in the risk, sometimes in the risk category. If you achieve an MRD negativity, you seem to do well. Whereas if you don't, and you still have apparently standard risk cytogenetics, the patient's risk category is higher, or they do worse. So we have to work through both these approaches moving forward: risk-adapted therapy and response-adapted therapy, trying to aim for the treatment which will achieve MRD negativity, and factor in the cytogenetic profile onto that as well. So this is some recent data from the US. Again, patients treated outside of clinical trials with VRD, showing the various outcomes, which are quite reassuringly very similar to patients treated off trial, because usually you find that patients who are treated off trial never do as well as those who are on trial. But the results of this study seem to suggest that at least there's not too much difference between the groups. But again, the negative prognostic parameters in this patient population remained high cytogenetic risk for both PFS and OS. The ISS3 remained a high risk feature as well. And maintenance is very important. I mean, you can see that patients who, some of the patients on that cohort were treated before maintenance became routine therapy, and they did much worse. So there are other the next drug, which is carfilzomib, which is thought to be a bit more effective than Velcade. And when that's added into the mix, as seen in this Forte study, again, the model remains the same: induction, transplant, consolidation, and maintenance. But here there was an arm with more intensive maintenance, which is carfilzomib and lenalidomide or Revlimid maintenance versus standard, which is Revlimid. So so intensive, this schedule. And I'm only focusing on the cytogenetic risk groups. And again, there's the concept we spoke about earlier, which is the more 2+ high-risk cytogenetic abnormalities. You can see that group does worse, even with the most intensive treatment or most effective group of drugs that we've got currently without the monoclonal antibodies. Of KRD, when you have 3 2 or more cytogenetic abnormalities, they almost certain to, or most patients will have progressed within 3 years. This is to hammer home the point about transplant in the high-risk cytogenetic groups. This is an analysis of 3 phase 3 EU studies with very long follow-up, and all the and all the data shows that the group that benefits most from transplant is the group with high-risk cytogenetic abnormalities. So you can see the difference in the survival curves for this group of patients who was treated with single versus tandem transplant, so 2 melphalan autografts. There does seem to be a benefit for a tandem in this group. Now, of course, some of these patients were treated in the pre-VRD era. The maintenance strategies may not have been uniform, but still, I do consider tandem. The only group of patients where I consider tandem autografts is in patients with high-risk cytogenetic abnormalities who still don't have a deep response after their first autograft. So but otherwise, pretty much, I think we've given up on tandem transplants at this stage in other patient groups. So this, again, to remind ourselves of the Mayo risk-adapted therapy classification, and this was their paradigm, or the most recent that I could find on their website. For transplant ineligible patients, they've just gone for daratumumab, Revlimid, and dexamethasone, and there's not too much difference, or you can treat with VRD followed by len maintenance. So there's not too much difference because the addition of the daratumumab seems to abrogate some of the cytogenetic risk status. It's a bit more complicated for the transplant eligible group, but here again, there is agreement that tandem transplant can be considered in the cytogenetic risk group. Now, the highest risk group that we're talking about, the ultra risk group, ultra high risk group, with the double or or triple hits, again, tandem autologous transplant, and they've got a bortezomib plus lenalidomide maintenance till progression. So that's pretty intensive treatment. Now, in my experience, most patients can't tolerate more than 6 to 8 cycles. So somewhere between 32 and 44 doses of Velcade. I've never had anybody. The neuropathy becomes a problem after that. So I mean, it'd be interesting to see how, from these studies what proportion of patients actually can keep going on bortezomib. Now, but there is one study for recent data available from the last ASH meeting for ultra high risk myeloma. And this is where the field needs to move, and it's a UK cooperative group study. And they've been able to, it's a phase 2 trial, but from their previous large cooperative group study, which was myeloma 11, they've managed to pick out a group of patients who absolutely can match at least this cohort of patients who've been treated like this. And so that is a comparative group. And so it's very intensive treatment. It's quintuplet induction. So DARA CVRD, so C is cyclophosphamide. A transplant, then again DARA VRD for 6, so that you get a quadruplet consolidation for 6 cycles after the transplant, and then 12 cycles of just DARA VR and maintenance DARA R until progression. So this is a very, very intensive and very expensive form of treatment. But it's the high-risk group is defined by greater than 2 high-risk abnormalities, so not just one, which all the historical groups have had one. And I think VRD or DARA-VRD can abrogate the risk of one cytogenetic abnormality. But when you get 2 or more, as we've shown before, then things become a bit more difficult. It takes all the recent data into account. So deletion 1p is in the risk groups now, which the historical studies haven't had that. We've got the gain 1q, we've got a molecular risk signature, and we've got plasma cell leukemia. So this is a really, really tough group of patients. And the outcome measure, the primary endpoint was progression-free survival at 18 months. So, relatively younger population as we would expect for anyone who's planned for such intensive treatment. And you can see the double hit, a significant number of patients, about a third with double hit myeloma. And it is deliverable because at least it's about 75% of patients who went through treatment actually completed the first consolidation block, which is, you think beyond that, they get maintenance, so that's relatively better tolerated. You can see that in comparison with the historical cohort, there is improvement in outcomes, and for the primary endpoint, which is that 18-month PFS, there is a significant difference in PFS between, and this is the first time that any strategy has been shown to, if you remember the previous total therapy 3 regimen, it didn't move the survivals by much for the high-risk group or that double hit group. Here, there seems to be more hope with this kind of approach. And the overall survival is also, as we move out further beyond 2.5, 3 years, there seems to be a difference in the overall survivals coming through as well. And there's reasonable follow-up, median follow-up of 3.5 years. So, and again, they've looked at MRD negativity, and for a high-risk group of patients, very large proportion have reached MRD negativity. I'm just going to skip over some of these slides. Well, I suppose one of the important things is they managed delivery of treatment very aggressively, making sure patients stayed on treatment, which is very important through an intensive schedule like this. And these were their conclusions, and that the very intensive, aggressive therapy, putting all the eggs into the first basket and keeping going with treatment may be beneficial based on the treatment modalities we've had before. There's another important study which is purely based on high-risk cytogenetics, which is a German phase 2 study, again with ISA-KRD, with transplant and again consolidation and maintenance, which will read out over the next few years. So it'll be interesting to see whether these 2 studies, which have very intensive treatment schedule, how much they move the survivals. Now, when it comes to response-adapted therapy, that's based on MRD. We know the deeper the level of, or the lower the level of MRD, the deeper the response, the better the outcomes in terms of time to progression. And the deepest type anybody's looked at is at that threshold of 10⁻⁶, which is only achievable with molecular MRD data. But with flow, we can get 10⁻⁴ to 10⁻⁵. Probably what is most achievable across multiple sort of out of trial or out of research environments is 10 raised to minus 5 by flow. And that is what most of the studies are taking forward. The next generation of studies are taking that threshold of 10 raised to minus 5 forward. So this was the HOVON study, which VCD, so a previous generation of drugs, which was looked at. And this study, the MRD data showed that it doesn't matter whatever the risk category, whether you're cytogenetics, LDH, ISS, if you've achieved MRD negativity, and the patient will do better. So that, and this is across all groups, which favors MRD negativity. So one of the first very large trials for response-adapted therapy was Myeloma 11, which randomized patients who did not achieve either an MR or a PR after their initial treatment to, this was the first randomization was basically between thalidomide and lenalidomide or Revlimid. And those patients who didn't achieve or have a very good response with their first round of treatment, they were randomized to go straight to transplant or have or change over to bortezomib-based therapy, and then go to the autograft after that. And there was a maintenance randomization afterwards. And it's shown, I mean, the study's clearly shown that if with this strategy, a response-adapted strategy, patients do better, significantly better. And it also showed, in line with many of the maintenance studies, that patients who are on maintenance do better. But there was some debate about IMiD maintenance versus proteasome inhibitor maintenance in high-risk cytogenetic patients. And this lenalidomide-based maintenance study showed that patients who were on lenalidomide did well, even in the high-risk subgroup. So that's pretty much standard of care now across post-transplant, or even for non-transplant eligible patients, is lenalidomide maintenance after whatever initial treatments delivered. So that's where we are now. Where are we moving to? Of course, CAR-T is the buzzword for everything now. So just to look at some recent CAR-T data, the first generation of CAR-T studies looked at patients who were beyond 4 lines of therapy. Most of them were like 5 and 6 lines and beyond, and proved the efficacy in that cohort. Now it's being brought forward into earlier lines of treatment. This is the KarMMa-3, which is multiple different standards of care of therapy versus CAR-T, and it showed a benefit for PFS, which was the primary endpoint. And this was published earlier this year in the New England Journal. And there's a significant proportion of patients with high-risk cytogenetic abnormalities, which we can see. And the one thing that with these immunotherapies seems to be clear is the cytogenetic abnormalities often don't impact on response rates. And the response rates seem to be reasonably high or pretty close to the non-cytogenetically high-risk group. It's the maintenance of the response, which, while better than our previous therapies, is still not the same. So that's the message that seems to be coming through from these studies. So, how can we, or what can we do differently in the high risk group? Now, this is the phase 2 KarMMa-2 study with early relapse. We know that patients who progress early following their initial induction therapy, they do much worse. And that early relapse is usually less than 2 years or 18 months, which was used for this study. So, so this group of patients had CAR T cells immediately if they were early relapses. And again, they had a reasonable proportion of high-risk patients, high tumor burden, patients with high-risk cytogenetics. So we usually about 30 to 40%. And this is, again, one of the first studies which defines the ultra-high-risk cytogenetics. So it's that terminology is coming into use more and more. There were about 10% of patients. And very high response rate as expected. And but with CAR-T, we're looking for more than just a simple CR. We're looking for stringent CRs, so immunophenotypically negative in the bone marrow. And we've got about 40% of patients getting to be into a stringent CR, which is why the immunotherapies are so exciting. Now, the other study which is being followed very closely, every update of survival from the CARTITUDE studies, the CARTITUDE-1 and the CARTITUDE-2 studies with cilta-cel, which does seem to be the most effective agent we've ever seen in myeloma, with close to 100% response rates and again 40-50% stringent CR rates in patients who were even treated beyond 4 lines of treatment. And this is the 2-year update that was presented recently in JCO. Again, showing that, well, the eye of fate, some at least the curve seems to be, other than that that initial drop-off in survivals, that maybe there is a plateau. We'll see. It's never too, myeloma is a disease where you never get your hopes up early, but it is encouraging that for follow-up 2 years and beyond. Whereas with the ide-cel, the previous CAR-Ts, the vast majority of patients were relapsing or have relapsed beyond a year of follow-up. So, and this is the data for the point that I was making about duration of response. So the response rates are very high for patients with cytogenetic, high-risk cytogenetics, but the duration of response is lower when compared to standard risk cytogenetic patients. So it's definitely, it may not be the answer in all patients with high-risk cytogenetics. There's a parallel study. I mean, the original cilta-cel product came out of China, and there is a parallel study called CARTIFAN, which has also been reported very recently, which show that they don't have data on duration of response, but they have data on response rates. And there, it's that point about it doesn't matter what the risk group is, the response rate seems to be very similar. And we've got a whole bunch of bispecific antibodies coming through, which have been reported recently. Again, this is the first one which has been approved, teclistamab, BCMA bispecific antibody, with an overall response rate of 65 to 70% in patients with 6 median prior lines of treatment. And again, about a third with high-risk cytogenetics, 40% with penta-refractory disease. And these are some of the others: elranatamab, the Regeneron product, the AbbVie product. There's a whole, and all of them seem to have at least about a 60% overall response rate. The question is going to be durability of that response. And the other problem that we're going to have to look at very seriously is the infection risks, because with this class of antibodies, long-term T-cell exhaustion, we're going to see lots of infections and atypical infections in this group. So the next cab of the rank is GPRC5D with talquetamab. Again, this early results seem to suggest that at least early outcomes are not impacted by high-risk cytogenetics. And there is the FCRH5 with cevostamab is the agent which is most advanced in its development. And of course, there are lots of other issues like CRS monitoring, in which we don't have time to get into at the moment. So this is where we're going to move in the future. We're going to look at CAR T cells post We're going to compare with the CARTITUDE-1 study. We're going to compare autograft versus CAR T cells after induction with VRD. Some people are arguing that you don't even need VRD. You may not need VRD or any form of treatment. Even induction treatment might not be needed. Why can't we just stabilize with whatever little bit of therapy while we're waiting for the CAR T to come in? So I think there's lots of very strong believers in where CAR T is going to be, but I think there's a lot of water to go under the bridge moving forward. Now, coming to the simpler stuff, and that we've spoke about right at the start, supportive therapy is very important. This is some data from the registry that we put out recently from the Australian registry. About 10% of patients are dying in the first 12 months after diagnosis. And yes, there is ISS risk group is in that group of patients. But other things like frailty, cardiac disease, comorbidities, infections, a big cause. I mean, some of them are progressive disease, or majority, but significant proportion have died of infection as the cause of death. And so there are areas that we can improve on outside of super expensive and not easily accessible treatments. And we need to do some of the simple things better as well. So that's just from that registry study, the German registry study, looking at causes of death in myeloma. And there's a whole series of other diagnoses, secondary malignancies. The more these patients stay alive, the higher the risk of other malignancies. Particularly, I mean, maybe the risk is increased by a bit by melphalan and lenalidomide maintenance. And this was also very interesting data, which from the registry, which shows that about lines of therapy and proportion of patients who receive lines of therapy. So a large number of patients receive first and second line, but the number of patients who actually go on to receive third, fourth, and fifth, particularly in the older age group beyond 70 years of age, there's a huge drop-off. And so having 5 lines of therapy is meaningless if it's not deliverable. So coming to my conclusions, so for this group, we can't compartmentalize our treatment for this group because we're never going to get there. They're never going to reach 4 and 5 lines of treatment. So we need to put all the eggs into one basket early on. Transplant remains important for now. Immunotherapy, you can say that word however many times, that's the future for this group. And designing trials well for both risk and response adaptation. And to end with, I think that what Dr. Yanamandra said resonated because it was exactly, I came across this on my BBC News app just last month. These 2 news items came up one below the other. One was about Dick Fosbury. Those who are interested in athletics will note that he was the one who revolutionized the high jump by this absolute new technique, which nobody had done before and nobody thought could be done. And then, so high jumpers were able to jump like much higher than they ever jumped before. So that's our new therapies. But it's also, this other news item, which talking about record players, which have come back into vogue and are now actually outselling a newer technology. So our older treatments are still very relevant, I think, in myeloma. And that's my last slide.
Thank you, Dr. Amit Khote, for that wonderful, elaborate talk, giving us a flavor of what's happening in the field of myeloma, especially this ultra high risk. Where are we going and what the future is going to look like. So we have some of our colleagues who may like to interact with you, maybe
Sure.
some comments, maybe some questions. We have Dr. Chirag Shah raising his hand. Chirag, go ahead. Okay, till Chirag asks his question, can I ask you one question? So
Sure.
as of today, would you say that based on the genetic studies, the patients who are falling in the ultra high risk, that means they should have what, minimum of 2 abnormalities?
So it should be, and that's where I think what's clear is if you have 2 or more of the high-risk cytogenetic abnormalities, so you get a del 17p plus a 414 or del 17p plus a 1416, you get or you get some of the molecular abnormalities in combination, like biallelic TP53 mutation or these 1p deletion or a 1. So if you got some of those individually, like if you get biallelic deletions of TP53, that on its own is bad. If you get biallelic deletions of 1p32, that is really bad. Or if you combine some of the others, then they push patients into this high risk group, and those are the patients who we all see with our current treatments do badly.
So for the moment, can one individualize the treatment based on very bad genetics or 2 abnormalities or 3 abnormalities? So we like to give induction with 4 drugs and go on to double.
So I think that's accessibility of drugs is the question there. So in Australia, we have a sort of a public funded healthcare at the moment, which so you have to unless the government approves DARA in addition to VRD, which we hope will be done. But at the moment, I still have to give all my patients who are not on trial. I have to give them VRD, transplant, VRD consolidation and maintenance. Doesn't matter what their cytogenetics are. The one place where I do have leeway in individualizing treatment is the tandem transplant. So those patients who are not MRD negative and have high-risk cytogenetic abnormalities, and I will consider for a tandem transplant. So that's the only now in an ideal world, if I wanted, I would go for DARA VRD transplant, DARA VRD consolidation, and then DARA Revlimid maintenance. So that's what I. But I mean, which healthcare system is going to be able to afford this kind of treatment? So that's where the risk adaptation comes in. Is that if you get patients to the response adaptation is that if you get patients to an MRD negative state, and you can see that they're able to maintain that negative state for a year or so, then you may be able to pull back on treatment in that group. So it's not clear, what the best strategy is at this stage.
So 2 connected questions with your answer. One is whether carfilzomib will feature anywhere in your upfront treatment for these high or ultra high risk patients. And number 2, based on the MRD, the assessment, if even in a high risk or ultra high risk, if the MRD becomes negative, will you tailor your treatment or you will still remain aggressive? First is
in
about
an ideal world, if there were no restrictions on treatment with how badly these patients behave, unless there is some very significant trial data which says otherwise, I think it may be that most people would want to continue. Because once you lose control of these high-risk patients, it's very difficult to gain control back. So in an ideal world where there were no restrictions, I think we would want to continue. But it's probably not feasible. And that's why I suppose the immunotherapies, the ones that we're looking at moving forward, the bispecifics and the CAR-Ts. The CAR-T is a one and done, of course, treatment, and with the aim of cure. With the bispecifics, it may be that you don't need to treat patients continuously, that you treat them for finite periods of time. I think the answer is there. It's not in our current therapies.
And the answer to the first question, carfilzomib, will it feature in the upfront treatment?
Yeah, I think carfilzomib does. It is a more effective drug than bortezomib, And so the results of that the GMMG concept study, where they have ISA KRD, I think will be important in deciding that question. There are some other studies which have been reported out of the US in terms of KRD, where they seem to suggest that in the standard risk group, maybe transplants not needed. So yes, it may be, but carfilzomib, I think, is a more difficult drug in my experience to deliver than bortezomib with its cardiovascular issues and so I think yes, it probably does move the survivals a bit more than Velcade, but I don't think it's by a huge amount.
Right. So Chirag, your question.
Yes. Thank you, sir. Thank you for this wonderful talk. I have two questions. One is for a patient who has been treated 3-4 lines of therapy, and now his disease burden is not very high, but now he has agreed for transplant, and the M-band is at about 1, and then we gave him the next line of therapy, and M-band moved from 1 to 1.5. Should we take this patient for transplant or continue trying with another line of therapy?
So I think transplant high-dose melphalan is useful at whatever stage of myeloma treatment the patient is in. So, but I think, I mean, I suppose I would be a little bit concerned in terms of how much toxicity the patient has accumulated from their prior lines of treatment in terms of tolerability. And also that we may not see the same benefit in terms of transplant at this stage as compared to frontline, because as we said from that Sarkos plot that we showed, relapsed refractory myeloma genetically is a completely different beast to what it is at diagnosis. So yes, I mean, I encourage all my patients as far as possible to have transplants up front. And then sometimes we do a second transplant if they've relapsed 3-4 years down the line. But that's usually with the aim of bridging to some other form of treatment. So I would always follow it up with some maintenance treatment afterwards. So yes, if it's feasible and there's cells in the bank already collected, I would, and there's no other options, it's always reasonable to consider transplant.
So would this be a contraindication because the team is concerned that the M-band has moved from 1 to 1.5 and they would like it going down? Does that is that a mandatory requirement or?
I would say yes in the upfront setting. Where I always try and have very good disease control in the upfront setting. Not so much, I wouldn't think of it so much if we did have an effective agent. So for instance, if we had, I'm thinking more in terms of what I do with my, for say, carfilzomib based therapy, where we have carfilzomib in the relapsed refractory setting. So sometimes I give carfilzomib, get control of the disease, do a second autograft, and then follow up with carfilzomib maintenance. So if there is an effective regimen which can, with a reasonable chance of success, to get some response before the transplant, because I suppose the argument can be made that what you go into with the transplant determines how well you do afterwards. So if the aim is just that this is treatment for relapsed refractory disease and there's no other options, a change from 1 to 1.5 is not that much. So you'd say the disease burden is relatively small. So yeah.
The second question is in the front line, where we have a patient with double hit, 11, 14, and 1Q. And I've seen him in second opinion. He received his penta refractory, and then he's refractory to every line. He's never had a response. And then we added venetoclax. With that, he has had very good response, a complete remission in terms of ambient, except one site on a pelvic area is active on the PET-CT. So now the question for him is whether we continue venetoclax, DEX, or we go into transplant now. And we are concerned that with transplant, we would have to hold the venetoclax for about 3 months. And this is the only agent which has worked so far. So we would lose all that response. So what should we do?
I just thought, I mean, just the venetoclax and the one area of, I would radiate that one site and continue with the venetoclax. Giving venetoclax post-transplant is not something I've done, but in other areas, we find, particularly in the leukemia patients, the AML patient, it's a very myelosuppressive drug. It doesn't see cytopenias are manageable in CLL, myeloma, but in patients who've had transplants or myeloid issues, venetoclax cytopenias can be a huge issue. So I'm not too sure what the tolerability is or whether there's any data about effectiveness post-transplant. I would have thought that for this one, just if he's in a CR, otherwise one site can be radiated, continue with the venetoclax, and then maybe use the transplant as a salvage the moment he starts to progress. But as I said, in the 11-14, it does show remarkable response.
And I forgot to mention, we did radiate that area before, and now it is resistant. Post-radiation also, it is showing activity after some time. So,
okay, then that may be an argument to say if there is one site of refractory disease to take to transplant, but yeah, maybe low dose venetoclax afterwards. I'm not aware of how it will be tolerated post transplant.
Thank you.
I have a question both to Chirag and Dr. Amit about this patient. Do you really give importance to 11-14 translocation upfront in a newly diagnosed patient, and do you really start venetoclax-based therapy upfront in any patient? And does this qualify for a double hit, triple hit, high risk 11-14? Because that was not the usual translocation mentioned in the double hit, triple hit, or high risk.
No, that's a good question. It's not it's not part of the upfront treatment paradigms, and in general, 11-14 seems to be in the standard risk or maybe intermediate risk in those sorts of groups. And venetoclax use is all in the sort of relapsed refractory setting. So it's not a, but I suspect that there were these additional cytogenetic abnormalities aside from the 11-14,
only one,
which made the disease high risk, yes.
He had 11-14 and 1Q, and after he was penta-refractory, we added the venetoclax, and this is the only regimen which has showed any response. Earlier regimens, 0 response.
Yeah, it's because it's a driver mutation. It's you see some remarkable responses in that. Yeah.
Thank you.
There's one question in the chat box related to whether you do the cytogenetic studies at each relapse.
I would ideally I would like to but it's not done routinely outside of clinical trials. The cytogeneticists, there's a limited resource, and they tell us that until you can prove to us that it's going to change your treatment, you have to show that you're actually going to use the data. So right now it's only in the research environment.
Thank you. Siddesh, your question.
Good afternoon, sir, and thank you for a wonderful lecture. In practical case scenario outside of clinical trial, how are you using MRD data in high-risk myeloma patients to decide on dual maintenance versus single maintenance? Because you mentioned that there is difficulty in tolerating dual maintenance in most of the patients. So how do you do that practically?
Yeah, I should have actually put up what we have access to as standard of care. As a standard of care for us is VRD, transplant, one or two, VRD consolidation, and maintenance. So it doesn't really matter what the cytogenetics is or what the so I don't have access to combination treatments or DR or Dara or Revlimid in the maintenance setting outside of a clinical trial.
And Siddesh, anything more?
Sir, I wanted to ask about bortezomib and lenalidomide as a maintenance therapy after transplant, and it seems people are finding it difficult in tolerating it over the period of time because the mention is about indefinite therapy. So
Oh, yeah.
in
So
that
that-
case, if the patient has become MRD negative, would you cut down on the dual maintenance and would you just continue with single maintenance, even if patient has got something 414 or like 414, definitely bortezomib will be there, but if 14, 16, 14, 20 or any other high risk marker is there?
Okay. So that's a good point. So the way I stretch out my bortezomib is I usually give it for maybe 6 cycles as per the label, with the weekly dosing schedule, and then after that, to stretch it out, I usually go to fortnightly. And then maybe give it for as long as possible on the fortnightly schedule. Because, but I have found that neuropathy, once you've reached beyond 40, 50 doses, that invariably neuropathy is an issue. And sometimes this can creep up and be like really painful and really impacts patients' quality of life. So I would, at the first signs of significant neuropathy, I would stop the bortezomib and continue only with Revlimid maintenance.
Thank you so much.
Okay. One more question from the chat box is related to PET scan based diagnosis of high risk myeloma. If you have more than 3 focal areas, will you treat them as high risk?
The data seems to say, I mean, that kind of speaks to partly. So a lot of the SPED data is based on retrospective analyses or sub cohorts of clinical trials. There's been no PET directed approach for treatment. So I think it all fits into that whole group of extramedullary disease. And I use PET much more as a for response assessment rather than risk stratification. And also, like the case that was described before, for escape clones, which are behaving differently in different sites.
Thank you. Kanksha, your question.
Thank you, sir, for that excellent talk. I had one question. Can kappa chain multiple myeloma change to lambda disease or vice versa? In case of long-standing cases, sir. It's known post-transplant, but can it happen in the pre-transplant setting as well, sir?
Not that I've seen. I mean, I've seen changes from sort of intact paraprotein, patient with an intact paraprotein progressing as a light chain escape or becoming non-secretory. I have not seen. I would wonder if what I've seen is 2 different populations of plasma cells at diagnosis, and so you get one clone which is lambda secreting and one clone which is kappa secreting, and then sometimes I suppose theoretically one of the other clones could take over afterwards. But to change from, I mean, by definition, that clone is secreting only one type of light chain. So I can't see a mechanism by which you can flip from one secretion of one light chain to the other. I would wonder about whether there was another subclone with a different light chain.
Okay, sir. Thank you, sir. One more question, sir. In case of isolated renal involvement of myeloma, one patient was there which was diagnosed based on renal biopsy, but the creat was not GFR was around 54. After that, how do we do the response assessment for her? Apart from the GFR is not, it's improved a little. So how do we do response assessment?
I'm sorry, I didn't get it. So is it like a just a plasmacytoma in the kidney, or is it
No,
a
sir,
myeloma kidney
it's
with
multiple myelomas. It's multiple myeloma only, sir.
so there's cast nephropathy?
What is the
Light chain
biology?
restriction biopsy. Biopsy was diagnosed, and light chain restriction was there. And she also had other features of
And
crab
but what
anemia.
was what?
Anemia.
But what was in the bone marrow? What was in the? Was there any light chains in the blood or paraprotein or?
No, sir, it was not there. She was a non-secretory.
But there was a clone. But there was something in the bone marrow.
Not in bone marrow, renal biopsy, sir.
Akanksha, let me put it this way. So your kidney biopsy has shown light chain in the, like a cast kidney,
Yes, sir.
right? Okay.
Yes, sir.
And in an
Yes.
established case of myeloma.
No, sir, that is how we diagnosed her. That
Okay,
was
but
at
retrospectively, myeloma workup was positive or negative? The blood,
She
the
could not. No, sir, her myeloma was
we didn't get it. Myeloma workup was
SPEP and SIFE were normal.
okay. So bone marrow was normal, hemoglobin
Yes, sir.
normal, no paraprotein, no light chains, nothing. And there is a light chain in the kidney.
Bony disease was there, sir. Bony disease and renal disease.
Okay, so I mean, I suppose what maybe we're all struggling to work out is if it's non-secretory, then where is the light chain in the kidney coming from, or what's secreting it, and how that's work. Yeah, tricky one. I'm not sure. I mean, I was thinking more in terms of other entities like monoclonal gammopathy of renal significance, or those amyloid, or those sorts of things. I mean, if you're convinced that there is a clonal myeloma population or plasma cell population which is and you said there was bony disease, so I would use the bony disease as a marker, maybe with PET scan, to work out response. As you say, the renal impairment may stabilize but may not improve. Yeah.
PET may always not show the response, no, sir.
It may not. If it is positive, then it will. Yeah.
Okay, sir. Thank you, sir.
But otherwise, I would probably say if you stabilized it, then a time-limited course of therapy with some maintenance, induction maintenance after that. Yeah.
We were planning to take her up for transplant. So before that, we were thinking whether it's really fitting into that response or not.
I don't think this is a very tricky case. At least I haven't come across one like that before. So I'm actually thinking as I speak, really.
Thank you, sir. Thank you so much.
Thank you, Akanksha. Another question from the chat box. There is a case who has relapsed within few months after autologous transplant. What is this patient's prognosis, and how will you change his treatment?
It depends on what treatment he's had beforehand. So I mean, without
the question now, it was treated with VRD.
Yeah, so these are a really tricky group of patients. And that's where those studies of immunotherapy are picking up these group of high-risk patients with using. So if there was access to a clinical trial with maybe with an or access availability of CD38 based monoclonal antibody therapy, I think that would be very useful. In combination with, I found that carfilzomib, a combination of carfilzomib and thalidomide, a lot of patients who are refractory or have suboptimal responses to VRD or early progressions, the combination of carfilzomib and thalidomide seems to work pretty well in that group of patients. But I think if there was access to CD38 based treatment, that would be very useful.
Yeah, we have daratumumab, pomalidomide, both these are there. Dr. Gautam, your question. We can't hear you. Unmute yourself.
Sorry, sir. Hi, sir. Thank you for the nice presentation. So, sir, what are your comments on the role of allo transplant in fit patients who are basically high-risk myeloma or ultra-high-risk myeloma?
I'm glad you asked that question, because I had one slide for allograft. I took it out. There's still, even now, you still see in Myeloma International or any other international conference, the occasional allo study still being, there are still some believers. I used to be a believer up to about 5 years ago. I've done a few auto allos up front, but all my patients, I mean, the numbers are small. All my patients have relapsed. And the studies seem to show from the long-term data out of the US studies and from which were done about 20 years ago, is that if you follow patients for long enough, there may be about 10% of patients who are cured, but 90% of patients relapse. So the survival curves beyond 10 years out show that there is a plateauing at that time point. I mean, in the early follow-up, there was no difference between auto and allo. In fact, auto was coming out ahead because of the early mortality from the allograft. But I mean, to cure 10% of patients with an allo, it's and this, you know, when you've got so many, you can get 10 years of survival using non-allo-based treatment. So even though I am an allografter in my other life, I don't transplant patients with myeloma anymore. Allograft.
Sir, what are your thoughts on radio genomics in myeloma, like radiological and clinical pictures?
I'm sorry, you're not coming through.
Am I audible, sir?
Yeah.
Sir, what are your thoughts on radiogenomics in myeloma, like incorporating the radiological and clinical pictures for predicting the cytogenetics?
I don't have any experience or knowledge of that area. So you're talking about signatures, various radiologic signatures for.
Yes, sir. Yes.
No, it's not an area that I've come across with or been involved with. So I'm not, but I'm not aware of that. Yeah.
Thank you, Dr. Gautam. Before we go to Dr. Thank you. We'll take one more question from the audience. The question is related to the technology to assess the genetics. The data is all fish-based or NGS-based?
So all the vast majority of studies are all fish-based analysis. But now, I mean, I suppose there's increasing an appetite to take on things like SNP arrays moving forward. So I suspect in future, the long-term future is that there'll probably be like whole exome or whole genome sequencing, at least at diagnosis. But NGS and I suspect NGS and SNP arrays will, because they're a bit easier to do, at least, but requires the bioinformatics know-how. I suspect in the next 10 years, that's probably going to be the technology that will take over.
Thank you. Rajan, your question.
So thank you so much for your talk today. I have a question which some might call naive, but still I'll go ahead. Do you always prepare for tandem transplants in ultra-high-risk myeloma?
Yes, I would always think about a tandem transplant and mention this right at the start. And then sometimes if a patient doesn't tolerate their first transplant very well or doesn't want to have a second transplant, then that comes into the equation as well. But from purely a disease-based assessment, I would always be thinking about a tandem right from the start. Yes.
And what percentage of your patients would need that?
Very few. I would say that's a good point. Actually, I didn't mention that this ultra high risk population is probably in that less than 5 to 10% of the patient population. The high risk is probably around 20 to 25%. I mean, 75% of patients are going to do well with, you could argue, VRD, KRD, with or without transplant maintenance. And they will have upwards of 10-year survival. It's this less than 5 to 10% of this ultra high risk group. That's the one where we need to do something differently.
And second, what are your thoughts on role of BCMA directed CAR-T in this subgroup? in upfront setting?
That you would hope that given everything else that we've done so far isn't working very well, that it will be of benefit. The Cartitude-2 study, one of the cohorts has a high risk and ultra high risk arm. So we'll get some information from that, and then all the other studies. So like the Cartitude-6 study, which is the cilta-cel, the BCMA directed CART, that is CAR T-cell therapy is going to be offered to everybody. So instead of a transplant, so you get half the patients who get transplanted, and the other half who get the CAR T. So because that will be a very large study, which will have a significant number of high-risk patients in both arms, we should be able to make a call as to how effective it is in the high-risk group. But that study is going to take, won't take, I suppose for the high-risk group, it won't take that long to read out. For the standard risk group, it will take a decade or so to read out, I think.
Thank you so much.
Thank you, Dr. Rajan. Another question from the chat box is, how do you treat high-risk smoldering myeloma?
The short answer is I don't. Yeah, I know those recent results of the ASCENT study and the GEM-CSER study. So we're still debating. We still get questions from patients about why we're not getting Revlimid or Revlimid alone or Revdex for the high risk in the high risk setting. So I think that generation of studies was done before the IMWG changed its myeloma defining events to the 60% plasmacytosis and the change in the light chain ratio to more than 100. So I think that took out some the proportion of the highest risk smoldering myelomas. Now the question is whether the patients who are left, whether we're going to aim for cure in that group using. And I think it's a bit ambitious, and we need a bit more data and follow-up before we start subjecting patients to such intensive treatments for asymptomatic disease. So short answer is I don't at this stage.
Thank you. Dr. Sandeep Shah, your question.
Thank you for a very excellent talk. And my question is whether those patients who are transplant eligible and after 4 VRD, if they are not getting a VGPR or still M band is persistent, whether you take patient for transplant after 4 cycles or you will give another few cycles and then take patient for the transplant.
Oh, excellent question, because I've just been debating that with one very patient in the last few weeks. So what I did with that one is he wasn't high-risk cytogenetics, but he didn't achieve a VGPR after his first transplant. So gave him 2 more cycles of VRD and discussed with them that if he tolerated his first transplant really well, that if he's not in a VGPR after 2 more cycles of VRD, we'll go for the tandem then. Fortunately, he did get into a VGPR, so we've held off the second transplant. And the way it was framed, the question was framed in that setting was in the previous generation of transplant studies, tandem versus single transplant, was only the patients who weren't in a VGPR who benefited from the second transplant. But all those studies were done before the novel agent era or combination novel agent era. So it's difficult to apply that data directly.
So the further question is, you give consolidation cycles post-transplant, means 4 VRD and then autologous transplants and then
2
consolidation
VRD.
cycle.
2 VRD, yes.
To every patient, or if after transplant there is a MRD negativity, then also you give 2 VRD or?
That intuitively you would feel that they won't need it, but we don't have that data yet. Those trials, those response adaptive trials are still reading out or have not read out yet. So if the patient has had significant toxicity or is really unkeen for further treatment and they're MRD negative, then I would say it's probably safe to stop and just go straight to maintenance. But based on what we know currently, current data, if we're still following an empiric paradigm outside of trials, so ideally they should receive it.
So ideally we should consider that 2 cycles, consolidated cycles of VRD as a standard of care for all patients.
Yes, because that's what our current treatment paradigms are based on.
Okay, thank you very much. Thank you very much.
Thank you, Dr. Sandeep. Another question from the chat box is, are there patients who are ineligible for CAR-T therapy?
So if we look at the patients who are on where CAR-Ts will first be authorized in the US or likely here as well. So the current label is beyond 4 lines of therapy. So there will also be a performance status, which will be a minimum performance status that will be required. And that we're kind of gaining some experience from our lymphoma colleagues who are quite who have had experience in trying to improve patients' performance status, even in the context of active disease, to get them eligible. Because if they're ECOG 3 or more, I mean, all the trials will probably have the majority of patients ECOG is 1. I would say those the older, frailer patients will, where if they're not able to tolerate the toxicities of CRS, cytokine release syndrome, those would be, I think they would not be candidates for CAR-T. I mean, they need to be, there's so many issues in that they get lymphodepletion with fludarabine and cyclophosphamide, which can sometimes be associated with long periods of cytopenia. If they've got significant renal dysfunction, it's difficult to give the fludarabine. So there's the whole neurotoxicity issue as well with the CAR-Ts. I mean, they're very effective, but we do see the occasional patient with significant neurotoxicity. So so that it's treatment that is very logistically, financially, and challenging in many different fronts.
There's one more question related to this line here. Uncontrolled myeloma and organ dysfunction, can we still go for CAR-T?
So the way we are thinking about the bigger the disease burden, and that's across all disease settings, the higher the chance of complications of cytokine release syndrome, neurotoxicity. So the way we're looking at things moving forward is wherever we're going to use CAR-T cells, we would prefer to have not rapidly progressive disease. Would like to have at least stabilized the disease or debulk the disease somewhat before heading with whatever form of bridging therapy. And I suspect that those will have to be individualized on what patients has received before. And we may even be going back to things like low-dose chemotherapy and things like that to buy that little bit of control and a little bit of response before moving to the more effective therapy.
Thank you. Dr. Kunal, your question.
Hello, sir. I just want to ask about the melphalan 140 mg per meter square dose. Is it valid for ultra high risk patients?
That's I suppose we're cutting that data in 2 different ways. One is MEL 140 versus 200. What is the efficacy? And then second is in so the answer, I suppose, is as much melphalan as you can get in is beneficial. I would give it if the patient was, if you felt that 140 was the only dose that was deliverable. So I would still give it, but we know that every time we cut the dose of melphalan, we're compromising on efficacy a little bit, not by a huge amount, but we know that we're so yes, I would still give it, but very reluctantly.
Thank you, sir.
Thank you. Another question from the chat box is related to myeloma with secondary amyloidosis. Does your treatment approach change?
No, only if there is a significant cardiac amyloid. So if which patient with heart failure because of cardiac amyloid, those patients are often they improve over time, but even if they're younger, often don't improve enough to get to transplant. So we've recently had and the only place we can actually access daratumumab in frontline therapy at the moment is in the context of amyloidosis, AL amyloid. So, so if it was, if Dara was available in that setting, I would probably use daratumumab. Yeah.
Thank you. Dr. Neeraj?
Yeah. Thank you so much, sir, for educating us. We learned a lot from your talk. My question is with respect to the TP53 mutations or any other mutation. So since cytogenetic forms a backbone of the stratification, do you in your routine practice do any other mutation testing or any molecular markers by any way?
So we do the FISH panel. We do standard cytogenetics FISH panel, and we've just about now begun to start looking at patients from a molecular with an NGS. So so that's very recent. It's a very recent change.
And do you change your treatment or modify your protocol in any way because of that information?
At the moment, it's the tandem transplant, basically. That's the question that gets answered with this information, not in any other way outside of a trial.
Okay. And one more question, since I'm a hematopathologist, like you did mention with respect to the plasmablastic myeloma. So does morphology in any way help you predict or suspect that ultra high risk or high risk myeloma, and do you use that information routinely?
So there's only two situations where I use, actually that's a good point. I'm glad you brought it up, because there's only two situations where I use chemotherapy or like a VDT-based regimen. That is in the context of plasmablastic myeloma and plasma cell leukemia. So now if say, ideal world, we get access to the quintuplet therapy like in that Optimum trial, the UK trial, cyclophosphamide, Velcade, or no, cyclophosphamide, carfilzomib, or whatever, IMiD, daratumumab, then maybe we won't need to use the combination chemos. But yes, for plasmablastic, younger patients with plasmablastic disease and plasma cell leukemia, I use VDT-based chemotherapy as induction.
Thank you so much.
Thank you, Neeraj. Bharat, your question.
Sir, not achieving MRD negativity post VRD in this ultra high risk myeloma group, will you consider switching to carfilzomib, venetoclax, or DARA before transplant?
No, I would use I would switch based on classical response criteria. So based on their paraprotein. And the MRD data is very interesting and intriguing, but we don't know enough at this stage. It's more, I think over the next 5 years, we'll know a bit more. So my current decision making is not based so much on MRD. As I said, in response to the previous question, maybe if there's a question about tolerability, if you think patients not tolerating treatment and they become MRD negative post-transplant, maybe then you could think about, okay, do they really need, what's the benefit of giving consolidation in that way? But I think the MRD data is still is intriguing, but early. We should still stick to making decision based on classical response criteria.
And based on classical response criteria, also if patient has not responded, then will you consider switching to add some more or modify adding carfi, venetoclax, or DARA before transplant, sir?
Yes, so that is where we have very clear data based on that at least in with those drugs that were used with the myeloma 11 study, is that getting to a better response pre-transplant? The benefit is significantly improved post-transplant in the progression-free survival. And that has been known right from the start, that the bigger the disease burden pre-transplant, the worse the outcome. So, I mean, we've known that for the last, more than 25 years, ever since we've been doing big studies in transplant.
And in such patients after transplant, will you consider different maintenance or any consolidation or maintenance difference?
So it depends on if they're stable disease. If they're progressive disease, you need to change. If they're stable disease, then I would take them to something different. So if my routine practice now is VRD, they're not responding, go to KTD, and then transplant, and then do carfilzomib maintenance afterwards. So that's how I do it. Post-transplant, so the question of them having gone to transplant with suboptimal disease rarely comes up now. Or sometimes the other issue is that there are the other place where I use if the patient's got really kinetically aggressive disease, proliferative disease, and is progressing very rapidly post VRD, then I could maybe consider a chemotherapy-based regimen for disease stabilization pre-transplant.
Thank you, sir.
Thank you. Dr. Ankit?
Yeah, thank you, sir, for that wonderful lecture. I have two questions. First is in continuation with what you had already discussed regarding ultra-high risk feature in a smoldering myeloma patient. I know currently we don't advocate starting treatment, but would you be in favor of including these patients as well in a myeloma patient, though they are asymptomatic, but including them in myeloma patient group and start treatment? Logically speaking, if we are allowing the clone to increase and increase the tumor burden, then later on we have a ultra-high risk disease with CREB criteria, then that patient would be more difficult to manage. So what are your thoughts? And
those are logical arguments to make. The problem is, at this stage we don't have the data from the trials to back this up. So I mean, those two studies that were presented at ASH in that high-risk smoldering myeloma group, if the final results of those studies are in favor, then I think there will be a much stronger argument to make for treating those patients. But I mean, the results of those, the Spanish study and the SWOG study for Len and Lendex, they came out like nearly 10 years ago, at least 5 or 7 years ago, I think. And that's still not been adopted as standard practice. I mean, even though there was a significant improvement as expected in the progression-free survival and possibly an overall survival signal as well. So I think it's justifiable to, at this moment in time, based on those two studies, to do Lendex or lenalidomide, because there is good data from two large phase 3 studies. Anything beyond that, to go the current generation of studies are being aimed at cure, which is a whole different argument. So I think Len and Lendex is justifiable, not anything more than that.
Right. And my other question is regarding the bispecific T-cell engager antibodies, especially directed against BCMA. This is clinically relevant for us because we may have early access to one of the product on compassionate basis. So how would you select a patient once he is fulfilling the eligibility criteria for starting a BiTE antibody? So is there any particular areas where you would select a patient for BiTE antibodies? Because it has to be a monotherapy, and we may have to stop dexamethasone and other anti-myeloma agents, and wholly depend on that particular therapy alone.
So I think that's great to hear that because this is one. I know I made the whole maybe to make turn that aircraft carrier around again because the one thing with I've gone on about we don't do risk adapted therapy, we treat everybody the same way. But what these immunotherapies may end up doing is actually if they're having the same response rates in all different types of myeloma, whether it's cytogenetically high risk or not, or with the other risk features. And so they may salvage a significant proportion of that population. Then it really doesn't matter that if a patient is fit enough in terms of performance status, they still get CRS, but lower grades of CRS generally. But it's still possible to get a little bit of CRS when the step-up doses are going in. So, we don't give them to the frailest patients who are not on the trials anyway. So that I think that would be the single biggest barrier to treating patients. In terms of, again, they're more likely to get higher grades of CRS if they've got a lot of disease. So if it would make sense to treat them early at early progression rather than with large burdens of disease. But we have seen really good responses, even patients with large burdens of disease. So, and generally the good thing with the bispecifics in some ways is that I didn't go into this, but the responses occur within the first month. So, and the CRs which occur, median time to CR is in 3 months. Median time to response is in a month. So know very early whether it's working or not. And generally it works in up 60% of patients it works. So the one part that I'm worried about with the bispecifics is the infection risk. This chronic T-cell redirection, we've already started to see those sorts of infections, CMV, Cryptococcus, all that spectrum. So I think tuberculosis, all those sorts of things would be a big consideration.
Right. So that was my follow-up question regarding the use of IVIG. Do you routinely use in all patients, or would you use in those patients who are having recurrent infections or have active infection on board?
No, I don't routinely use it. If the patient gets a significant infection or gets multiple recurrent low-grade infections, then in that situation.
Right. Thank you so much.
Thank you, Ankit. One more question has come up in the chat box. This is related to going back to the fish studies. Are there clear-cut cutoffs for calling a particular abnormality as positive and negative, percentage-wise?
That's a very good question, which I would presume a very accurate pathology question. And these are the kind of things I think gets debated when you're reviewing papers. So it seems to be that somewhere between a 30 to 50% cutoff for these various fish abnormalities. That's where the most of the studies have come in. So it needs to be a significant clone. It needs to be a big clone. Just having a small clone doesn't seem to impact on the overall outcomes. So, but there's different cutoffs for different. But the literature is varied, and when you ask that question in the trial or research setting, I think a lot of people just pick an arbitrary number.
Thank you. Dr. Jyoti Sane. Jyoti, are you there? Okay, Dr. Nidhi Jain. Some problem. Dr. Meenu.
Yes, sir. My question is regarding IGH, for 1Q, the 1Q gain and 1Q amplification. We are doing myeloma panels, and in many cases, we are finding only 1Q gain. All other markers are negative. So those cases should be stratified in high risk or not?
So the data for single just 1Q abnormalities, the initial debate was whether it is 1Q just amplification of 3 copies versus 4 or more. So amplification versus gain. And there's again varying data based on that. So they all, I think 1Q gain, 1Q amplification, they definitely increase the risk somewhat. But if it's combined with something else, 17p or TP50 mutation, then or a 414, then there's 2 or more abnormalities, the risk go up significantly. My feeling is, again, the problem with the single abnormalities is that none of the studies look at these abnormalities as and the responses to various treatments as single abnormalities. All of them get clubbed together. So it's very difficult to tease out what the impact of each signal abnormality is. So I would say it should still be reported as a potential high-risk abnormality, but until our treatment paradigms will not probably change around that. It's the same, that the age-old thing about myeloma risk stratification is we find it very difficult to tease out and treat according to each abnormality.
Okay, sir. Thank you, sir.
Thank you, Dr. Meena. Another question in chat box is related to maintenance therapy. Is there a clear-cut data that double drug maintenance is superior to lenalidomide alone?
No, not really. We're doing a current trial in Australia where we're trialing selinexor, Revlimid versus Revlimid alone, standard of care. So that's one. There's my feeling is that so there's no not that I'm aware of anything that's shown superiority for dual agent. I suppose that previous generation of studies there was some benefit for bortezomib and Revlimid put together in the ultra high risk or the high risk cytogenetic group. So I think that is justifiable. Again, delivery is a question. I can't see any patient tolerating long-term bortezomib maintenance. So so I think short-term consolidation / dual agent maintenance in the ultra high risk setting is justifiable. But then followed up maybe a year's worth of dual agent treatment and then followed up by Revlimid maintenance single agent.
Thank you. Uday, your question.
So few comments. I have no questions. First of all, thanks a lot to Dr. Amit for a wonderful deliberation for almost over 2 hours. So a few things. So the anemia prevalence and what the data you are referring to during your lecture about the article that we had published. So yes, we also are parked with the type of the various CRAB manifestations that the patients in India have. This year for the ASH, we are submitting data of 24,000 patients from 62 centers. So probably we'll get better. We'll get better information. So that was single institutional. Now this year we are going to come up with a multi-institutional data as an ASH abstract. Now coming to a few points which you actually answered, that is MRDs. Dr. Kalantri had asked regarding body continuation when the MRD is negative. At least the practice, because we have just concluded a 5-year trial on post-transplant MRD monitoring with 6-monthly MRD monitoring using both PET as well as flow cytometry. And we have found that if a patient is MRD negative by 3 years persistently, if he is having a persistent MRD negative for 3 years, then we are withdrawing the maintenance therapy, whether it is irrespective of the risk category before the transplant. So, and irrespective of the type of maintenance, because there were different arms, we give some patients IMiD maintenance and some patients proteasome inhibitor maintenance. But just to say our experience, so we stopped the maintenance after 3 years of persistent MRD negativity post-transplant. Now, there was a second question regarding the PET positivity and relevance. Again, we have a data of PET pre-transplant and post-transplant. As you rightly brought out, there might be these represent escape clones because there is no reason why myeloma cells should be outside the marrow. So if somebody is having PET positive and extramedullary disease, definitely they have a poorer disease. But yes, as was pointed out by the panelists, they definitely indicate high risk. Now, does that warrant a change of therapy or not? As you rightly brought out, it would be a matter of trials and future data needs to come upon it. So let's see that how it comes up. Now, lastly, regarding the kappa to lambda transformation, as was brought out by one of the panelists. So maybe it could be clonal evolution, or as you rightly brought out, two clones initially, one clone not being very prominent or getting hidden in the other clone, and one clone getting suppressed and the other clone coming up in a biclonal manifestation. Could be the reason for having a kappa is to lambda transformation pre-transplant, but post-transplant it's very common because of various reasons, immune reconstitution, which can happen. So these are few comments, sir, but otherwise we thoroughly enjoyed the way you deliberated on the topic. Thank you, sir.
Most welcome. Yeah. Great. I'll keep a lookout for your data. It'll be very interesting.
One more question in the chat box is related to definition of plasma cell leukemia. A percentage of plasma cells by morphology and percentage of plasma cells by flow cytometry on peripheral blood. What will be taken as plasma cell leukemia in today's time?
I think that's again a question that is evolving. With the moment you see plasma cells morphologically in the blood, I mean, you know they've escaped their niche and it's a more aggressive disease anyway. So from a practical standpoint, if I see a significant number of plasma cells in the blood outside of a clinical trial, I would treat them with a more aggressive regimen. If from a definition perspective for a clinical trial, then that sort of the absolute number of 2, the 20% threshold. Some argue that even that's too high. 5% threshold might be the right threshold. So that's an evolving question. But I think the moment you see circulating plasma cells, whether in primarily or in secondarily in myeloma, that's bad news.
Thank you. That's the last question from there. Any question from the faculty here? Okay, if none, then this is the time to thank you, Dr. Amit Khot. Okay, one question is just come up. I think you can clear that. Allotransplant you already answered. So thank you very much, Dr. Amit Khot, for sparing your extremely valuable time, being with us for such a long period, giving the lecture, patiently answering all the questions. It has been a tremendous knowledge gaining by junior and senior colleagues all around. And as I mentioned to you, we have registration from 27 countries. So a lot of people have heard you today, and the care of patients from all over the world will be better from tomorrow. Grateful to you for sparing your evening. Thank you so much.
Thank you. Thank you very much.
And
Thank you, sir.
To all the faculty members here. Thanks to our sponsors, and thanks for the event management team. Bye-bye. Have a wonderful Sunday after. Bye.